thank you for the invitation, and thank you for allowing us to share our data. This is my disclosure slides. CAR-T immunotherapy, after a long journey of revolution, the technology become more and more mature, especially in treating the hematology malignancy. From these slides, you can see that current CAR-T clinical trial filed worldwide under this clinicaltrial.com. And you can see in China, which is quite active in CAR-T treatment. And this is current China CAR-T IND filing status, total 29 companies, many products, and still a lot of companies are still waiting to officially file the IND. We actually, since 2015, been collaborated with multiple CAR-T companies and has completed more than 500 CAR-T cases of under the clinical trial in our single institute, Ludaopei Hospital. By the way, we are hematology hospital. So I will show some of our studies here. And the first is our CD19 CAR-T treatment for refractory relapsed B-cell ALL patients, including subgroup of high-risk patients. The CAR-T was provided by Beijing immunopharmaceutical companies, and it is a second generation of a CAR-T, which is CD19 directed, containing distinct intracellular domain, stimulated domain, and expressed in a high percentage of early differentiated T cell. And total 1110 patients enrolled from April 2017 to May 2018. After enrollment, the peripheral mononuclear cells are collected and sent to the CAR-T company for manufacture. Then as a clinician, then we try to stabilize this patient disease and provide them a preconditioning regimen of fludarabine and cytoxan. Once CAR-T cell infused, then pretty much is toxicity management and then the assessment. This is a basic characteristic of our 110 patient. You can see the age from 2 to 61. And the bone marrow blasts can be as high as 96%. Near half of those patients have very poor complex cytogenetic abnormality, and quite a large population patient cohort are extramedullary disease and also BCR-ABL positive ALL, as well as TP53 mutated patients. So the median follow-up is 234 days, with median infused CAR-T cell is 3 × 10 to the 5th per kilogram. Other CAR-T features are all listed here. So let's take a look at our day 30 complete remission rate. So on day 30, CR plus CRI can be as high as near 93%. Most importantly, those are deep MRD negative CR per flow cytometry analysis, up to 87% of them. Only one CAR-T related death. As a matter of fact, that patient died from infection, severe infection. For our high-risk subgroup of patients, you can see the CR can still be varies from 78 to all the way to 100%. So what is the long-term efficacy of those CR patients? So 75 out of 102 patients, after they achieved the CR from CAR-T treatment, subsequently underwent allo-transplantation, including 2 had a second allo-transplantation. 10 out of 75 of those patients eventually relapsed, with the median relapse days 225 days. So 8 is bone marrow relapse, 2 extramedullary relapse. The 5 deaths, please note that our transplant-related mortality are extremely low. Here we only have 3 patient deaths here related to transplant-related mortality. 27 out of 102 patients without allo transplantation, including those 14 patients were to start with was post-transplant relapsed patient, then received the CAR T treatment, therefore not able to receive the second transplantation. So 13 out of those 27 patients, 48% patient eventually relapsed with a median relapse day 90 days. When they relapse, half of those patients CD19 positive, half of those are CD19 negative. So you can see the leukemia-free survival at 1 year for the whole cohort still can be as high as 70%. So the patient received the CAR T treatment, then bridge into the allo transplantation, doing much better than CAR T treatment alone. You can see both from OS and leukemia-free survival. Majority of patients will develop some degree of CRS. However, you can see 83% of those patients, CRS actually is quite mild, mild to only moderate. And the same for neurotoxicity. Most common side effects are fever. So far, the 2 major co-stimulator domain is 4-1BB and CD28. In our study, we found out the 4-1BB CAR T group had better leukemia-free survival as compared to the group in CD28, and 4-1BB group also has less side effects. So let's take a look close about our high-risk subgroups patients. First group is high tumor burden patient. We have a total 18 patients. The definition here, high tumor burden, is if they are bone marrow blasts greater or equal than 70%, you can see those high tumor burden patients, their CR can still as high as 78%, certainly lower than the low tumor burden group patients. The BCR-ABL positive or pH positive ALL patient, how they are doing. We have a total 14 patients in a group. Day 30, the CR rate in this group is 100%, and 86% is MRD negative CR. 8 out of 14 patients bridged into allotransplantation with no relapse. 2 out of 6 without allotransplantation eventually relapsed. So the BCR-ABL positive versus BCR-ABL negative group, their OS, leukemia-free survival, basically shows no statistically significance from CAR T. We all know that ALL patients with TP53 mutation are, generally speaking, are poor prognosis patients. We have a 12 patient in this group. Their day 30 CR is not bad, 92%. However, they have a quite high relapse rate in this group, 5 out of 11 relapsed. Compared to TP53 mutated patient versus a no mutation patient, the OS and leukemia-free survival are much worse in the TP53 mutated patients. So here come with the extramedullary disease. We have 23 patients in this cohort, and their CR rate 86%, 87% versus 94% without extramedullary disease. You can see a trend towards worsening of OS and leukemia-free survival in extramedullary disease patients. More detail in CNS leukemia patient, we have 17 patients, and 14 of those cases, we have a very detailed CSF flow cytometry study. You can see the median blast count was 275 per cell. And the blast, they all, except one, just CNS leukemia without bone marrow involvement. Other patients are simultaneously also have a bone marrow involvement and a blast count as high as up to near 96%. Their CR rate is 76%, a little bit lower as compared to without the CNS leukemia patients. However, the 9 out of 15 of those patients still leukemia-free, and the 2 patients subsequently relapsed at 2, 4, 4, and 8 months. And the people worry about whether a patient with CNS leukemia will have a more toxicity. In our experience, are actually controllable. Only one case had a neurotoxicity, but under control. So can patients relapse after allo bone marrow transplantation still benefit from CAR-T treatment? We have 16 patients in this cohort, and 11 out of 16 patients before CAR-T treatment had at least one donor lymphocyte infusion was ineffective. And before enrollment, no patient had active GVHD. And after CAR-T treatment, their day 30 CR rate can be as high as near 94%. 4 out of 16 patients had a more grade 3 or 4 CRS. Other patients were have a relative mild, moderate CRS. And 1 patient had a grade 1 acute GVHD, 4 had chronic GVHD, but no one died from GVHD. 6 out of 16 patients still remain CR in 3 to 20 months. Actually, 2 out of those 16 patients even had a second allo transplantation. Currently, 1 patient is 20 months out, 1 patient is 5 months out, leukemia-free and doing very well. So conclusion from this study is the high CR rate can be achieved for refractory relapse B-cell ALL patient with CAR-T treatment. CRS is manageable, and many high-risk patients can still benefit from CAR-T treatment. And the CNS leukemia is not absolutely contraindication for CAR-T treatment. The inferior OS and progression-free survival, leukemia-free survival was observed in TP53 mutated patients. In our experience, the OS and the leukemia-free survival was significantly better for patients who received CAR-T treatment, then bridged into the allo transplantation than those patients with with CAR-T treatment alone. And the 4-1BB containing CAR appear to have some advantage. So we all hear the duration of CAR-T treatment are still problematic. Can we bridge them into allo transplantation, further increase their cure rate? So here is, we have 135 patients in this study enrolled from November 2015 to March 2018, age from 2 to 49. And near 80% of those patients receive haplo transplantation, and then another 15% are match and related donor. As you know, in China, many years one-child policy, so it's hard to find a sibling donor. The engraftment for WBC and platelets median engraftment was 14 days. So the OS and the leukemia-free survival, we can take a look our 2 years data, and the patients group. If you can have the patient achieve MRD negative CR from a CAR-T treatment, then bridge them into allo transplantation, their 2 years leukemia-free survival as high as 80% versus patient if they achieve the MRD positive CR with the CAR T treatment, then bridge them into transplantation, their long-term survival or leukemia-free survival will be lower than those MRD negative group. So the conclusion that CAR T followed by allotransplantation was a promising modality, and it is very important to achieve MRD negative CR before transplantation to reduce the relapse rate. This is really a teamwork. We appreciated all the team appreciated CAR T company provided the free CAR for our clinical trial. And thank you for your attention.
Thank you so much, Dr. Liu, for discussing these beautiful data. There is room for 1 or 2 short questions. Yes, please go ahead.
Wonderful study. Did you assess the frequency of CAR T cells in the CSF of your patients with leukemia in the CSF, cerebrospinal fluid?
Could you repeat that again?
Well, you say that in patients with the CNS involvement, so blasts in the cerebrospinal fluid, CSF, you could clear the CSF from blast, which is a good message. Now, to show causality, it would be nice if you can detect CAR T cells in the cerebrospinal fluid. And that's my question. Did you do that, and which method did you employ?
We do have analysis also check there whether to see the CAR T cell in the CSF. We also use flow to check it from the patients and able to detect some of the CAR T cells. Yes.
Last question.
Were you doing measurements of the pharmacokinetics, the cell number of CAR T post-infusion? And how did that relate to outcome either with or without subsequent allotransplant?
The kinetics of the CAR T cells. That's the question? Disappearance or persistance?
We routinely, actually on our clinical protocol on day 1, day 4, day 7, day 14, day 30, etc. We routinely check their CAR T peak, their persistence, etc. We use flow cytometry, flow analysis at the time of day 30. Use a flow analysis, only small persistent CAR T, you can detect it. However, we think the flow actually is not that sensitive. If we use quantitative PCR, we can find out they will persist longer. And so because our experience is the CAR T treatment, yes, they give you very high day 30 CR. However, the relapse are still the problematic, especially for very high risk patients. So what our strategy is, we use the CAR T treatment as one of the modality, not the only modality, to hope we bridge them into the transplantation will further increase their cure rate, because once they relapse from the CAR T, actually those patients not really have much of the option left.
Thank you so much for the final comments. I would like to hand over to Eliana, my co-chair.